Hello. My name is Daniel Lawrence from the RockTech UK team. Thank you for joining me. Here I have sciatica patient Mr. Drazy, who has the good fortune to find himself here under the most auspicious of circumstances with you and I in this presentation on sciatica, lumbar spine, radiculopathy, and piriformis deep gluteal syndrome. The big question we will attempt to answer in this presentation is, can manual therapy help patients with sciatica? And if so, what should we do and not do based on the available evidence? This presentation is broken down into 7 parts, which are as follows. A brief overview of sciatica-related facts. What predicts a positive or negative outcome? General manual therapy approaches. And then more specific manual therapy approaches that we can try for our patients suffering from lumbar radiculopathy. We'll also look at what not to do and a presentation on which pain medications are effective or ineffective for sciatica. We'll then have some conclusions and sources of further information. Thank you, thanks for joining us. Let's get started. Now, sciatica is not something you can diagnose from a scan or a blood test. It's a presentation of signs and symptoms in clinic. The key signs would include unilateral leg pain, which is worse than the back pain, and also pain radiating down below the knee, often down to the foot and the toes. Numbness and pins and needles can also occur in a specific distribution, which is often down the back and the lateral side of the leg. And there'll also be the reproduction of pain with a straight leg raise, typically quite early in range, between about 30 to 70 degrees. And the patient will be very resistant of you lifting their leg any further. We also look out for specific muscle weakness, particularly in the plantar flexors of the ankle, where there may be reduced power or even lack of enough power to create a functional lift in the heel raise position. It's also common to see reductions in dorsiflexion power and reductions in eversion. You also commonly get dampened deep tendon reflexes, so the knee-jerk reflex and also the ankle or Achilles reflex. So many of you are probably already familiar with those signs and symptoms, but for those of you who weren't, those are some of the classic signs and symptoms of sciatica, also called lumbar radiculopathy. Sciatica is a clinical diagnosis with defined symptoms. Any unusual symptoms should elevate suspicion, and either a referral, second opinion, or further assessment should be arranged. It should also be noted that there is an increased risk of epidural abscess in patients with a history of IV drug abuse and those with immunocompromised health status. Your typical spinal red flags for cauda equina would include bladder or bowel incontinence, urinary retention, and leg weakness. I discussed these symptoms of cauda equina syndrome in much more depth with my colleague Mike Grice in a webinar hosted on the Physio channel on YouTube. It's available for free, and if you want to find it, just look for the PDF in the link from the Teachable platform, or visit the Physio channel on YouTube. So what causes sciatica? The sciatic nerve is made up of nerve roots from L4 to S2. The nerves combine to form the sciatic nerve as it exits the pelvis and then goes down the back of the leg. The sciatic nerve itself is the largest nerve in the body at around 2 centimeters in diameter. The nerve exits the pelvis through the deep gluteal muscles, down by the hamstring origin, then down the back of the leg deep to the muscular tissue, and then begins to divide and branch off before crossing the knee, where it then divides into more divisions down into the lower leg and foot. Now, sciatica is most commonly caused by compression at the nerve roots, most typically at the level of either L4-5 or L5-S1. Less common are the deep gluteal syndromes, which occur in the deep gluteal tissues and are most commonly referred to as Piriformis syndrome. And this type of presentation is very different as it's more muscular, more peripheral, and more easily treated with manual therapy and exercise. The patient is also much less likely to experience central pain processing changes with peripheral nerve irritation when compared to nerve root irritation. Of all your patients with sciatica, about 10% of them will have a peripheral irritation in the deep gluteal muscles, and these patients are often easier to work with. So I'll be showing you on this presentation some strategies for dealing with that pathology, as well as strategies for dealing with the more common and problematic lumbar radiculopathy. All right. It has been suggested that compression and inflammation are two separate mechanisms of nerve root irritation. The nucleus propulsus of the disc can chemically irritate the nerve and cause pain without the need for compression. And a reduction in nerve mobility from a disc bulge may not directly compress, but may trigger edema and the release of inflammatory mediators. Direct compression of the nerve often leads to more severe motor dysfunction, and it's possible to have muscle weakness and sensory loss without pain. You may have seen this in your clinic when a patient with persistent foot drop comes in after their pain has long since resolved. So they can be often two very different presentations. It's been suggested that there may be a more whole body systemic driver for sciatica, especially in the elderly, but it's difficult to draw firm conclusions based on the available studies, so that still remains in question. Other causes may include more rare presentations like spondylolisthesis, tumours and foraminal stenosis. So, what predicts a positive or negative outcome at 12 months with patients suffering from sciatica? The aim of this part of the presentation is twofold. One, to share the likelihood of a positive outcome with patients using the available recovery data. The aim is to provide a positive outcome expectation, which the evidence shows can be very much a self-fulfilling prophecy. Explained another way, patients have a better chance of recovery if they believe they have a good chance of recovery. The positive outcome expectancy is not unique to sciatica. We see it with many other musculoskeletal conditions. But for sciatica specifically, it's one of the strongest predictors of outcome. The second aim of this part is to understand how manual therapy can help influence the other outcome predictors. Perhaps helping a patient to move from the likely negative to the likely positive 12-month recovery group. So, in terms of a positive outcome message, on average, the research indicates over 50% of patients will recover within 12 months. But the most positive data I could find was that around 3/4 of patients with sciatica experience a full recovery in 3 months. This is what I routinely share with my patients. 3/4 of patients with sciatica experience a full recovery within 3 months, without the need for medication and without the need for surgery. While you can certainly find less positive outcome research, the aim here is to create a positive outcome expectation, which in itself would help to create more patients with positive outcomes. On balance, when you read the available literature on this subject, it's evident that a proportion of patients still experience persistent and disabling symptoms after 1 year. Now, I hope the information I share today helps to keep your chronic cases to a minimum. What about manual therapy? A study by Constantinou and colleagues in 2018 involving 609 patients reported that secondary problems attributed to the sciatica were independently associated with a negative outcome at 12 months. So what were these secondary problems? Well, they included back pain, leg pain, inability to sit comfortably, fatigue, stiff joints, sleep difficulties, and a loss of strength. The presence of one or more of these was associated with a more negative outcome at 12 months. Manual therapy can help with more than half of these problems, and that's what we're going to look at in this presentation. Let's start with the back pain. By treating any associated back pain, you may begin to nudge the patient towards a better outcome, even though you're not directly treating the sciatic nerve. And there lies an important message from this presentation: treat the patient and not the sciatic nerve. Now, the manual therapy you choose needs to suit the patient. You could try some simple spinal rotation mobilization techniques like this. And I like to augment the spinal mobilization with a rock pod to grab a hold of the soft tissue around the most tender and restricted area, so that I can add in some soft tissue mobilization with some gentle spinal rotation mobilizations as well. Overall, rock pods can provide a very effective and therapeutic treatment for tension and lower back pain. The negative vacuum that the rock pods create really does pull on the skin and the underlying tissues and can be felt very deep underneath the skin for the patient. So if you've had these tried on yourself, and if you haven't, I would strongly encourage you to have a try because they feel absolutely amazing, is you really feel the movement of the tissues, not just where the pod is sitting, but because of the vacuum and the purchase of the skin, and the pod has really got a good grip, it's got skin as a handle, it's very effective at pulling on the tissues deeper and around the pod as well. And it can provide a very effective soft tissue mobilization experience, which often leads to increased mobility and reduced pain. So these little negative pressure handles are excellent tools for performing soft tissue work. And at the moment, I've just got Mr. Drazy here sitting still and stationary, and hopefully he's feeling the benefit of this rather small massage over his lumbar spine. But in keeping with the rock tape principles, we really need to get him moving as soon as possible. We need to get him moving to increase his range of motion. We need to get him moving to reduce the threat of movement and improve the psychological factors as well. And movement's always a big part of the treatments that we're doing. So from this position, we could ask him to start to flex forward and back up again. And when he does this, the external pull of the cups is working against the slide and glide of the underlying tissues. So we've got an internal shearing or an internal massage going on, even though we're not actually doing anything to the cups at this time. But of course, we could add in some treatment and get things moving superficially as he's also moving as well. So we've got external glide and internal glide, all the while trying to improve range and reduce lower back pain. It's not treating the sciatica, it's not treating the sciatic nerve, it's treating the associated symptoms of sciatica, which have been shown to be independent predictors of outcome. So we're treating a secondary issue with the hope and aim of making Richard more likely to be in that good outcome category at 12 months and hopefully, of course, at 3 months. Now I'd like to get Mr. Drazy moving a lot more, so I'm going to get him into a different position now and show you another technique, one of my favourite techniques actually, for improving lumbar flexion, reducing lower back pain, and it's just again a good treatment experience for patients. So let's have a look. So we're going to look here at a general lower back pain treatment technique. We're going to do a yoga pose called the child pose or balasana. Before I do it, I just want to make sure that Richard posteriorly tilts his pelvis and then drops back onto his heels so that we get a good amount of lumbar flexion, okay? Another tip for you is if the knees are together or close together, then there won't be so much available range from the hips, which will demand more flexion from the lumbar spine as they drop down into the end range hip flexion, lumbar flexion position. And back up again. Now I've put a little bit of the rock rub over the skin here just so that it doesn't get too reddened from the use of the tool, and I'm going to use one of these IASTM tools, the Rock Blade Mohawk, to work over the erector spinae. So I'm going to start over one side first of all, the side nearest me, over the erector spinae using that medium edge of the tool there. So from the back of the pelvis, I'm going to ask Richard to drop back and slowly move the tool through his erector spinae there, okay? And we're going to repeat that again on the other side. And the technique I'm doing here is slow slide, and for that reason I'm going to ask Richard to go slower as we perform the technique. So I've got moderate pressure, pressing in over the erector spinae. I've got about a 45-degree tool angle. I might increase that slightly to 60 degrees to get a little bit more pressure. But Richard's moving very slowly, which allows me to work through the tissues slowly, stimulating the nervous system in the correct way so as not to get a stimulus response and more of a relaxation response with this technique. All right, and I'd normally do about 5 or 6 repetitions, each one being really effective rather than doing multiple repetitions. I'm focusing on making each repetition really count. So each stretch really counts for Richard. You're moving slowly. It will also help if he exhales towards the end of range. Relaxing his rib cage is going to help him to drop down to that stretch a little bit further. Okay. So that's an excellent massage with movement technique. The patient's got to think about what's going on and move fluently and really make that exercise as effective as possible. And then you're adding to that with some soft tissue treatment, which you're consciously doing slowly with moderate pressure up over the erector spinae. This often works really well to reduce lower back pain, which again, if you can reduce those associated symptoms, then it's likely that your patient will be in that better outcome category as they're recovering from their sciatica. So let's have a look now at what else we can do for our patients suffering from sciatica. So those soft tissue techniques can be performed in different positions. Whilst you can lie the patient on their front and have them relaxing, and that's okay. In fact, we're going to do that in a moment, and I'm going to explain a bit more about why. It's always a good idea to try and get the patient moving, especially moving into those tight or dysfunctional positions, so that straight away you can start to improve the movement. And all the while, if you're improving the movement, breaking down that fear of movement, then alongside this is often a reduction in pain as well. So using the other rock blade here, we can perform some of the soft tissue treatments over the spine, and rather than the balasana stretch, Richard can just drop forwards into forward flexion as I do a slow slide down over his lumbar spine, taking advantage of the shape of the tool so I can go over both sides with the concavity in the middle, making sure I don't bump into the spinous processes. So that's a very simple technique that can be very effective for reducing tension in the lumbar spine. Vibration treatment is also very popular in the industry at the moment and has its place for pain reduction. So we can get Richard to do the same technique of forward flexion as I lightly pass this is actually a percussion tool, the flow, over the erector spinae. And last but not least, any rock tape presentation would not be complete without some taping. Now, many of you, of course, know how to tape the lumbar spine. If you don't, then this is a quick whistle-stop tour, but you want the patient in a pain-free stretch position. So Richard's going to sit in a forward flex position there, which adds a light stretch to the tissues without it causing any undue pain. I'm going to place the tape on the bottom of the erector spinae, so just over the back of the pelvis, and then without any extra tension in the tape, run the tape onto the skin with no stretch on the end. So there's really not much stretch in any of the tape, but I'm paying particular attention to the end pieces to make sure there is no stretch. As you can imagine, if there was stretch in the tape, then it would be pulling Richard's lumbar spine and having like a postural movement corrective effect, which if somebody's got a tight lower back already, you don't want to make it potentially tighter by putting tape which is pulling on their spine. So these pieces go on without any stretch, and then a wider decompression goes across the most tender and painful area. So I'll peel away the backing paper. I've rounded off the edges already, and then I can stretch. So let's say it was a little bit tender here. Stretch and stick the tape down. So this piece does have some stretch in the middle of the tape, but no stretches on the end. Okay, and then when Richard sits up, there's no tension in the tape, and you can see that by the ripples in the tape. Now, I know this is not treating the sciatic nerve and arguably not treating sciatica, but actually it is, because the research shows that the secondary symptoms, the secondary attributable problems, one of which of course we're working with here, the back pain, is associated with a poor outcome at 12 months. So if you can treat this secondary issue, the back pain, then it's going to put your patient more likely into that positive outcome category, even though you're not directly treating the issue of sciatica. So by reducing the back pain, by reducing the dysfunction, by reducing the disability that comes with back pain, you can often make patients feel a bit better or prevent them from getting worse, and this will help them in the long run. And it is worth explaining this to the patient, because obviously if they've got sciatica and you're treating their back, it's really helpful to explain why you're doing that, and that will really help to build the rapport and to build a buy-in for many of the other strategies which you're going to go through with them, which I'm going to show you in just a moment. Next, we have sleep difficulties, which is probably the cause of the fatigue as well.
Can you improve sleep with manual therapy?
Yes, you can improve sleep with manual therapy, and here's why. The pain, anxiety and stress that sciatica causes leads to an increase in sympathetic drive. This means it triggers the fight, flight, freeze response in the body, upsetting the balance of the autonomic nervous system. The correct use of manual therapy will hopefully reduce sympathetic drive and stimulate the balancing parasympathetic system, which is a neurological way of saying it's relaxing. And relaxation equals less pain, less tension, hopefully improved sleep, and therefore likely less fatigue. If you've ever had a massage, you will have probably noticed that you slept well afterwards. That's the sort of outcome that can significantly help a patient with sciatica. So try this. You want to target the parasympathetic system through the Ruffini nerve endings with moderate pressure and slow movements. And if you perform this over the posterior chain of tissue, so over the hamstrings, and then moving up over the erector spinae, and in anatomy trains they would refer to this as the superficial back line, but that's only one way of looking at it. There are of course other ways, but we're looking at this myofascial continuity dropping off the back of the pelvis into the erector spinae. The patient is relaxed because our ultimate aim here is relaxation and reduction of any tension that the patient is feeling. And this is not so much a targeted intervention, which is why we're doing the whole of the back of the body rather than just the sore area. And we're moving through the tissue slowly. The nerve endings that we're looking to target and to stimulate or depolarize are called the Ruffini nerve endings. And they sit fairly deep in the tissue, and they require sustained pressure to activate or depolarize. So therefore moving quickly over the tissue won't stimulate those Ruffini nerve endings, and also moving too lightly and superficially also won't do it. But on balance, you also don't need to put tons of pressure into the patient, because we know that tons of pressure pushed down into the soft tissue, particularly if it's tender and even if it's not, can cause a pain response, and with that we have an increase in muscle tone typically, and that's absolutely not what we're looking for. So we do need some moderate pressure. We are going to move slowly, but do modulate that pressure if the patient is finding that particularly uncomfortable. But hopefully, because you're moving slowly, It also will make the technique relaxing. If you were to move too quickly, again, that can often stimulate some discomfort and muscle tension from the patient, so try to avoid that. So moving slowly, working globally, downstream, upstream of the painful area, and moving over that whole posterior myofascial tissue. So coming all the way up the erector spinae would also be helpful. Remember, what we're looking for here is not treating lower back pain. We're looking at a general relaxation, which would hopefully reduce lower back pain, but because of a global reduction in tone rather than pressing over the sore areas in particular. So here you can spend a good amount of time, start right down at the calf if you want to, working up one side of the body and then working up the other side of the body as well. And another important point to highlight here is you don't need to go hunting for the sciatic nerve or even pressing and working around the glutes, because we're looking here at a less targeted approach to reducing muscle tone and reducing pain. Next, let's look at joint stiffness, a common sign of muscle guarding and habitual movement patterns. Here are some techniques to improve spinal motion with the aim of reducing the secondary effects of sciatica. This is one of my favourite taping techniques for improving rotation of the lumbar spine, particularly when there's a one-sided rotation restriction. I take a wide piece of tape, the 10 centimetre width, and ask the patient to stretch across with their knees over this way to the left and arms over to the right. So I'm creating a stretch through this left side thoracolumbar fascia. And because I'm starting here on the left side, this is for a patient that would have a restriction rotating to the left. So I take the tape there, and depending on patient comfort, it helps just to get the tape over the top of the glutes and then stick the tape down without any tension or paper off tension, which is a very low level of tension, but we're not adding any stretch to it. Once I get to the center of the spine, the upper side of the thorax here is actually in a compressed position, so I'm going to ask Richard to bring his knees over towards me and switch his arms over to the other side, so that I get a stretch then out through the lats on this side. And I'll continue applying the tape up, underneath and towards the axilla of that right arm. So this is for a restriction of spinal rotation if the patient is tight to the left. Okay, great. If Richard then kneels up with his back to the camera, we can see in the tape that there's certainly no tension, And I'll just bring you guys in a bit closer so you can see what's going on here. So you can see there's no tension in the tape, it's not pulling, and in fact there is some rippling in the tape. And then if Richard turns and rotates to his left, the tape is applied in a way that does not restrict that motion and should actually improve that motion as well. And certainly does not restrict his rotation to the right side, which wasn't a problem in the first place from our assessment. So that's just a quick introduction to the taping for the back functional line. It's one of the things that we cover in our taping day 1, but you could have a go at that if you wanted to improve rotation of the lumbar spine.
So how do those exercises and the taping improve my sciatica?
Well, that's a great question. We are treating the secondary problems that are associated with the sciatica. And if we treat them, you may recover faster. If we ignore them, then it's also likely that you may recover slower. So even though this session may not help you today, or to recover as much as you would like today, it could make a huge difference to how you feel in 3 months. Now, the good news is we've been able to identify these problems with you, and the trick is that we've now started working with you early with those interventions to help you with your back pain and your stiffness and the sleep, etc. So we can therefore try to reduce these becoming bigger problems and again put you in that likely positive outcome category.
Well, that sounds positive, but can't I just have some surgery?
Well, in our line of work, we're always trying to keep patients away from surgery or to help them to recover from surgery. So in brief, what the research indicates is that patients with a high degree of leg pain that persists are more likely to consider conservative treatment to have failed or be inadequate, so therefore they're more likely to seek further intervention in the form of surgery. The research also informs us that this patient group that gets surgery may be in a worse state when they first have the sciatica in the first place. So when they get any relief from surgery, it's often quite a significant relief. Now, what we also see in the research is that if the patient started from this lower level of function and more disability, then they can have a more short-term positive outcome from surgery in those cases. But at long-term follow-up, so usually a year, there doesn't seem to be a huge difference between surgical and non-surgical groups. So both groups that have had surgery or not had surgery seem to arrive at the same destination, and long-term follow-up for surgery is not as good as people would like it to be. But it does provide relief for those patients that are really struggling in the first instance. So surgery is an option. It's not a quick fix, and it's not a panacea or a hierarchical option really in terms of what you can do for sciatica. And here's another important fact, guys, I want to add into this presentation. About 90% of lumbar radiculopathy is caused by a disc bulge, and disc bulges usually spontaneously recover. That's one reason why surgery is not required in most cases.
So are there any techniques that exist to target the nerve and literally get to the root cause of the problem?
Yes, there are techniques like this one, for example, which is a nerve mobilization. But before you try these, Rich, it's important to understand how they might work, but also how they can sometimes make things worse. How's that? Yeah, making it worse. Before we move on, let me just do a quick whistle-stop tour of nerve biomechanics. On average, nerves are about 50% connective tissue, and like other types of connective tissue, they have layers. The deepest layer is the endoneurium, followed by the perineurum and the epineurum. Around the nerve trunks, there's also the mesenterium, which is a loose connective tissue that allows the nerve to slide and glide. Of note is the absence of a lymphatic system in the deeper endoneurial and perineural spaces, which may cause nerve dysfunction if edema from nerve compression is not able to clear efficiently through fluid channels. More specifically, any disruption to the nerve fluid flow may damage the nerve fibers. Now, the outer part of the nerve, which can account for the majority of the nerve's thickness, is called the epineurum. The epineurum does appear to have lymphatic channels, which drain into regional lymph nodes. And this provides a plausible mechanism of action for nerve mobilization to simply provide the movement pump needed to increase lymphatic flow through the one-way valved lymphatic vessels. Edema and lack of movement may cause a fibrotic buildup between the nerve and the surrounding mesenterium at the level of the nerve root. Whilst it's attractive to imagine that nerve mobilization is breaking down these adhesions, the reality is that this would cause excessive pain and possibly further edema, and nerve mobilizations may simply aggravate sciatic symptoms. Now, I've got Richard here doing some nerve mobilization or neuromobilization, or otherwise known as nerve flossing. And for you guys on the camera there, but also I use this with my patients, I've got some rubber tubing here to represent the nerve. This really helps to visualize this idea of the nerve gliding and nerve flossing rather than the nerve stretching. So if we were going to stretch the nerve, which we might only do for testing purposes, for example, Richard would have his leg up and obviously foot held up here. And then if he, from the slump position, was also to flex his neck, we can see that that total distance along the posterior is increasing, and this would cause nerve tension, which can often cause pain and be aggravating. And if there is some sciatic symptoms and sensitivity at play already, then this can often aggravate the symptoms for a period of time afterwards. So we avoid that, and we look instead just to work on the sliding of the nerve in a non-symptomatic way. This shouldn't bring about any symptoms. Now, it's unlikely that you can determine whether a patient can do this or not before you actually try it. So if you're going to try the nerve mobilizing techniques, be prepared to test them out and see whether they work for that individual patient. But be aware that in some cases, nerve mobilizations can be unhelpful in individual circumstances. Let me show you some other things you could try to target the sciatic nerve and the deep gluteal muscles. If you're looking for some more advanced and direct ways of trying to deal with the sciatic nerve irritation, then try this advanced sciatic nerve stretch, which we're going to actually build into some nerve mobilization and soft tissue work as well. So have the patient sitting on the side of the couch with their thighs together, and I'll show you this the other way around in just a second. And then have the patient lie down on their side, and as they do so, bring their knees off the couch and then let the lower legs drop, so that what we have is ultimately a side flexion through the torso, which is brought about by the leverage from their legs. To increase this side flexion, you could put a pillow or some cushioning underneath the pelvis here, but as these patients are often in high pain states, that sometimes is a struggle. But what's usually quite achievable is to bring the arm up and over and relaxed into that position there. And what we're doing here is opening up this side and trying to increase the spaces from those nerve exit foramen where those lumbar nerve roots come from. That's not easy to achieve, I appreciate, biomechanically, but if there is muscle tension there, then this, if anything, is going to be a nice long prolonged stretch which may ease that tension and give those nerve roots maybe just a little bit of extra space. We want to make sure as well that we've got a little bit of flexion in the lumbar spine, and we can also add in some rotation to see if that alters their symptoms, rotating one way and rotating the other way. Typically rotating this standard lumbar rotation can alleviate symptoms a little bit. But that's it, the patient can be taught this and can lie in that position. But I want to show you a couple of extra things, because from this position what we can also do is get one of the rock pods to use as a handle over the lumbar spine. So I'm going to put that over the level of L4. Of course we could go lower, but once we get that onto the sacrum, we know that we're really not going to have much influence on the underlying tissues. So I'll get that onto the L4 region. And then I can take the leg up, ask my patient to dorsiflex the foot, and I'm going to do a side-lying assisted slump slide nerve flossing technique. Okay, so I'm going to bring the arm back down into a comfortable position, and I'm going to ask my patient to flex their neck and also to slump through their torso as well. So we've got this side-lying slump position. Now he's got dorsiflexion in his ankle, but his knee is bent, so there shouldn't be any neural tension there. And when we do the gliding, the sliding, the flow, the flossing techniques, we want to make sure that it's asymptomatic, because if they do feel symptoms, it indicates that they're causing some irritation or increasing the sensitivity. And in those acute stages in particular, we want to avoid that. So it's a non-symptomatic. The patients literally shouldn't feel anything as they go about doing their nerve flossing techniques. And if they do, it's likely that you may have potentially irritate it and irritate it further, which goes against the grain a bit, because often when you're working with patients, they want to feel something, feel a sore bit, feel a stretch. Nerve mobilizations should be asymptomatic. They shouldn't feel anything, especially if you're executing them in the correct way. So we have the slump here, slump flexion through the neck, but not at the knee. So as I now start to straighten the knee, the patient knows what's happening here. They're starting to lift the head and they straighten the knee. I'm just guiding them there. I'm not forcing them. So Richard can straighten the knee as much as he likes and then back down again. It may take him a few repetitions just to learn what sort of range is available, but without any symptoms, without any feeling of tension or nerve pain, we can go about this side lying glide. Now, why is that pod there? Well, that's there because I can augment this technique with some soft tissue techniques, but it's also a handle. So I can try and mobilize the tissue in a certain direction. So I can mobilize that over to the right, or inferiorly if you're looking at it, pushing it down, and see if that alleviates the symptoms. If it doesn't, maybe I'll mobilize that the other way, superiorly, over to Richard's left, and see if that alters the symptoms there. So that rock pod provides a lovely handle for me to do some soft tissue work and a symptomatic glide to see if it helps if I glide it down, or helps if I glide it up, or in any other direction. And I'll take that away now. Okay, so let me just show you that if Richard sits facing the camera. And again, a lot of this the patient can do themselves. So knees together, side lying, and then from this position, if I start with the legs up here, okay, you've got the hips at 90 degrees and the legs come off, and then the lower legs provide that leverage to bring about that torso lateral side flexion. And the addition of the arm going up is an option, and the addition of a bit of rotation as well. So if Richard was to bring his arm back, if Richard was to place his arm behind his head and then rotate this way, then we can add in a little bit of rotation. All right, so that was the positioning. If that is a bit uncomfortable for the patient, then what you can do is just drop one leg off and see how they get on with that before you go ahead and drop the other leg off as well. Okay, so that's the sciatica stretch position, which we then used to do some mobilizing and added in the pod there to do some mobilizing over the soft tissue and at a spinal level as well. Now, I also wanted to show you this specific technique. If you're dealing with deep gluteal syndrome, most commonly known as Piriformis syndrome, then it makes sense that you want to get in and work on the soft tissues around the sciatic nerve to try and reduce the tone or free up the nerve, or however you wish to look at it. But the trouble is, whenever you do that, in order to get enough purchase on the tissue there, you're going to have to add compression. And you may have some success with working on those tender areas with compression style techniques, whether you're using your hands or acupuncture or a tool. But one of the great advantages of using the pods is the negative vacuum that's created doesn't add pressure. It actually reduces pressure and allows the tissue to be lifted, which, if you think about the nerve issue being ultimately about compression, then anything which lifts is going to be highly beneficial. So you can do some deep tissue work without the associated pressure. So you go ahead and get your pod over that mid-gluteal region there, and there's your handle, there's your decompression. You can add to that decompression by lifting the pod, and then when you start to move and mobilize the soft tissue, the effect is really quite deep. I'm sure Richard can feel that, and guys, get one on your own butts and have a go and just feel how deep that soft tissue and just guys, you can get one on your own butts and have a go and just feel how deep that soft tissue effect is as it mobilizes the soft tissue around that area there. So that can be highly effective and can actually feel really, quite nice, especially if you've got tension deep within your gluteals. So that's one of my favorite ways to use the rock pods, and also my patients report that it's very, very therapeutic and highly effective for getting into those deep gluteal issues as well. Okay, so that's really helpful for your piriformis syndromes. I just wanted to share that with you there. Have a go and see how you get on. This video looks at which pain medications are effective for sciatica. Here in the UK, one of the first interventions for sciatica-related pain is medication. But how effective is medication for sciatica, and what are the best options? Paracetamol. Paracetamol is considered no more effective than a placebo for standard lower back pain, and no high-quality studies exist to consider the effectiveness of paracetamol for sciatica. Any benefit is therefore likely to be simply from a placebo mechanism. Overall, non-steroidal anti-inflammatory drugs like ibuprofen are no more effective than placebo in reducing pain or disability associated with sciatica. While there may be some benefit short-term, the side effects of prolonged use should be considered alongside the weak evidence for their use. Benzodiazepines like diazepam, for example, have also been shown to be no more effective than placebo. And in one small trial, the drug actually increased the likelihood of experiencing pain for longer and was associated with a longer hospital stay when compared to the placebo. So not only was it ineffective, but actually had a detrimental effect on the patient's recovery. The evidence for anticonvulsants like gabapentin and pregabalin is a bit more mixed. One trial identified that gabapentin led to a statistically significant reduction in pain, but another trial with possibly better methodology found that pregabalin and a similar medication were no more effective than placebo to reduce pain and improve function at short-term and at long-term follow-up. And all of the trials reported a similar proportion of side effects in both the medicated and the placebo groups, highlighting that side effects themselves of the medication can also occur with the placebo medications, indicating that the side effects themselves may be subject to outcome expectation, which is one of the strongest mechanisms of the placebo effect. There is some evidence to show that antidepressants like amitriptyline can provide some relief from the pain associated with sciatica. But like all medications, this type can have considerable side effects, and I've had a small proportion of my patients report reactions to these types of medication. They are an option for some patients, and they may be helpful. Opioids are known as the strongest form of pain relief. However, one trial did not show any benefit of morphine over a placebo to reduce the pain associated with sciatica. And adverse events such as constipation and drowsiness were more common in the opioid group compared to the placebo group. So what's the conclusion? Well, if you're a patient, what this means is that there's no primary go-to medication for the pain associated with sciatica. And if you're managing a patient with sciatica, it may help to explain this to them that there is no evidence for any specific medication for sciatica, and that many medications have known side effects and little known positive effects on the symptoms. Often patients are unaware of this, and making them aware can often make a big difference to how they manage these sciatic symptoms. At the same time, we could explain the likely natural outcome of the leg pain, which is of course in most cases likely to reduce in a number of weeks, especially if they have a positive outcome expectancy. I had a patient report to me that they were very surprised to learn that there was little evidence for any of the medications that they'd been prescribed for their sciatica, and that they found this helpful to know, and also helpful to know that the sciatica-related pain should resolve on its own with or without medication. In this presentation, we're going to talk about what not to do. Nerves have a viscoelastic property, which means that the rate of loading is important. Even a small tensile load applied too quickly can cause pain and potentially damage to the nerve. So the speed of nerve tension is of importance. Now, nerves are remarkably sensitive to pressure, specifically elongation, which can cause occlusion of the blood supply, known as the vasa nervorum. Now, this can occur at levels as low as 10% elongation or lower if fibrosis has caused an increase in the nerve stiffness. This reduction or closing of blood supply is often very painful and can lead to further scar formation. Typically, in a non-traumatic event of a nerve being stretched, the pain and discomfort that the patient feels stops them from performing that action, stops them from progressing further, and of course stops them from damaging their own nerves. Now, nerve movement that we've looked at with the nerve mobilizations in a pain-free way can help to reduce the mechanosensitivity of the nerve. But be wary of anything which approaches a nerve tension technique. Whereas holding a muscle in a stretch may dampen the sensitivity of a stretch reflex, the pain associated with a nerve stretch due to the occlusion of the delicate microvascularity of the nerve, which creates the hypoxia and often quite a lot of pain. So holding this position with a no pain, no gain type of mentality is not something you should do, and if you do, probably only something you'll do once because you won't see that patient again. Surrounding tissues like the muscles can increase in tone, causing joint ranges to reduce, which can worsen symptoms and the likelihood of a good outcome. In fact, these detrimental mobility restrictions that we've been talking about earlier in this presentation can also affect the mobility of the nerve. And these mechanical stresses may actually cause or be one of the causes of the nerve irritation from a biomechanical perspective. So don't just do nerve mobilizing, even if it works, make sure you cover off the other things we've looked at in the presentation today. Although several studies have been conducted in order to identify the mechanisms of effect for neuromobilizations, the mechanisms remain largely theoretical. Lumbar radiculopathy and other spinal radiculopathies seem to be caused by a complex interaction of inflammatory, compressive and central processes. Psychologically, it's been shown that a positive outcome expectation is associated with an increased likelihood of a positive outcome. And wrapped within this thought process is a lower fear avoidance or a lower pain avoidance and better beliefs about patient movement. These behaviours, of course, should be encouraged, and we should encourage our patients to move more, engage in more rehabilitation and do things that generally lead to desensitisation. Desensitization from a lack of movement and pain avoidance behaviours should be avoided. It's been suggested that a nerve mobilisation may potentially worsen sciatica symptoms due to the input of further mechanical stress, especially in acute pain-sensitive cases. We've discussed this and have shown you many other evidence-based treatment approaches that you can use to deal with your patients with sciatica. For more information, please see the suggested links on the PDF download that's on the Teachable platform. Thanks for watching.